In this presentation, we will be talking about the American Academy of Sleep Medicine guidelines and recommendations for using sensors in polysomnography. In each section, along with the rules, you will notice recommended, that is highly advised to be used; acceptable, that can be used as alternative to the recommended rule; and optional, that is suggested to be used for uncommonly encountered events and benign events. So for PSG acquisitions, here are the recommended sensors. So we need to record 6 EEG exploring electrodes and 2 reference electrodes. Two exploring EOG electrodes combined with 1 reference electrode, tripolar chin EMG electrodes, respiratory flow. We need both of the nasal pressure and the thermal sensors, respiratory efforts, and here we need both of the thoracic and the abdominal, bipolar ECG, and bipolar EMG for both legs. Coming back to the EEG channels, we need to record the occipital region, the central region, and the frontal region of the brain. The 2 reference electrodes should be placed on the mastoid processes. This drawing shows how to make the recommended EEG montage in PSG. So we take the even exploring electrodes, which are located on the right side, and we combine them with the odd reference electrode that is located on the left side, and vice versa. When we record from the occipital, we will be able to maximally observe the alpha rhythm when the eyes are closed. And when we record from the central, we will be able to maximally observe the theta waves, vertex sharp waves, spindles and pseudospindles, and sawtooth waves. When we record from the frontal region in the brain, we will be able to maximally observe the K complexes and the delta waves. Those are called the sleep signatures that can help the scorer distinguish between different sleep stages. To locate our exploring electrodes, sleep techs should be familiar with the 1020 International System. And as in this picture, it's called the 1020 because the distance between the different channels has to be 10 and 20% apart from each other. In order to have a good signal quality and good impedance results, the following accessories should be used. The cotton-tipped applicators, and those can be used for having good exposure to the skin side by separating the hair. Also, those applicators can be used for abrading the skin. Abrasive skin gel should be used, and this gel can remove the dead tissue and the dust particles. And here are different types of abrasive skin materials. China markers or electrode placement markers should be used to locate our channels on the scalp. And here are different types of those markers. Measurement tapes, cup electrodes that can transfer the signal from the skin to the amplifier, conductive paste, and in this slide there are different types of conductive paste that you can choose from. Gauze rolls, and those can be used to get the skin dry after the preparation, and we can place one piece of gauze on the body of the electrode before applying the tape. That in turn can make it more fixed and more stable. Tapes and wraps, which are used to fix the electrodes and to make them stable throughout the recording. And here are different types of tapes and wraps that you can choose from. For more details about the types of the available sensors, please open the link below. The recommended method for EOG electrodes placement is as the following. We go to the right outer canthus, that is the intersection of the upper orbital margin and the lower orbital margin. We go 1 centimeter laterally and 1 centimeter up. Then we go to the left outer canthus and we go 1 centimeter laterally and 1 centimeter down. When we record EOG, we can get different distinct patterns of eye movements. Those patterns can help us in the differentiation between sleep stages. Tripolar electrodes. The central one should be located 1 centimeter above the inferior edge of the mandible. The other two should be located on the submentalis region, and those should be 2 centimeters apart from the central midline. When we record EMG for chin, we will be able to distinguish the transition from wakefulness to non-REM and from non-REM to REM. This can help us in distinguishing different parasomnias related to REM sleep, and also it can help us to diagnose bruxism. EMG for legs. Both legs should be monitored, and this technique is useful in the diagnosis of motor-related sleep movements disorders. Bipolar electrodes should be placed vertically over the anterior tibialis muscle belly, and those electrodes should be separated by 2 to 4 centimeters apart from each other. ECG. The negative electrode should be placed on the intersection of the midclavicular point and the second intercostal space. The positive one should be placed on the intersection of the mid-auxiliary line and the sixth intercostal space. The recommended electrodes for ECG are the snap electrodes, which attach to the patient by those pre-gelled patches. For the detection of respiratory conditions, flow sensors should be used. The gold standard for airflow detection is a pneumotachograph, which measures the drop across a linear resistance. However, This technique is impractical for PSG. Therefore, the American Academy of Sleep Medicine recommends to use the nasal pressure transducer with or without square root transformation. The nasal signal is sensitive to even subtle changes in airflow. Therefore, it's more useful in evaluating flow limitations and upper airway resistance syndromes. Nasal pressure monitoring provides a signal that is proportional to the square of the flow. This transformation provides a more accurate estimation of the flow. However, due to some factors, like changes in catheter position, the accuracy of the transformed signal typically deteriorates over the night. A nasal cannula sensor should be connected to the amplifier through the lower lock, and the nasal or oral tranches are positioned in areas to sense changes in pressure when the subject breathes. Then the pressure input is converted to an electrical signal. Biocalibration is a very handy tool that can tell us about the validity of our signals. The pressure flow signal should correspond to the given instructions. During inhalation, the signal should have a negative or upward deflection. On the left side of the trace, this is called the amplitude bar. This is the zero line, this is the negative polarity, and here is the positive polarity. And when we ask the patient to breathe, the upward deflection is the inspiratory phase. When filters are not applied for the nasal pressure signal, and when snoring, the signal should show flattening of the peak and a series of fast, low amplitude, and high frequency waveforms that represent snoring episodes, like in this example. Filters are not applied for that signal. The first trace, which is on the top, is the snore. The second trace is the nasal pressure. On the snore channel, we can see a series or clusters of snore events. If we go to the nasal pressure, obviously we can see the flattening, and here we can see the snoring episodes on the inspiratory portion. If we set filters for the nasal pressure, the tracing should show only the flattening. This is the same example that I showed you in the previous slide. Filters were applied. Low frequency filter was 0.1. High frequency filter was 15. If you look at the snore channel, here we have series of snoring. If we look at the nasal pressure signal, it shows only the flattening, no snoring clusters over the inspiratory portions. This slide shows you the different types of the available nasal pressure cannulas that can be used for the recording. Thermal sensors. Thermal can be thermistor, thermocouples, and PVDF films. This is an example for thermistor. This is an example for the PVDF. Thermistor and thermocouples. Sense the changes in air temperature during breathing. This sensor is a metal. The exhaled air would heat the wire, while the inhaled air would cool the wire. Considering the fact that cooling down a metal or warming up a metal would take time, that in turn would make that sensor less sensitive to partial obstructions and narrowing of the upper airways. Thermistor uses a single metal that detects changes in temperature and requires an electrical source. Thermistor is very sensitive for small fluctuations over a smaller temperature range than thermocouples. And because of this point, thermistors are more commonly and widely used rather than the thermocouples. Thermocouple uses dissimilar metals to generate electricity and produces a voltage which increases with temperature. Thermal sensor is the recommended sensor for scoring apnea. This slide shows you the different available thermistor and thermocouple sensors. PVDF sensor is a film that produces a signal that is roughly proportional to the temperature difference between the two sides of the film and have a faster response time than thermistors or thermocouples. Respiratory effort sensors. There are different techniques for recording the effort of breathing in polysomnography. The most recommended technique is the dual thoracoabdominal respiratory inductance plethysmography belts, and you can use either the disposable or the reusable ones. Spirometry is the gold standard technique for measuring lung volumes. However, it's impractical in sleep as it requires a conscious patient and sealed nasal air sensor. The RIP technique measures the changes in the thoracic and abdominal volume. This technology measures the changes in elastic belt tension and in electrical inductance. In order to have optimal and most reliable signal that comes from the thorax, you need to understand the following. If we go back to the anatomy of the rib cage, we can realize that the ribs are connected all together. However, from rib number 1 to rib number 4, the generated movement during breathing is anterior-posterior movement and a slight lateral movement. However, if you go to the level of rib number 5 and rib number 6, the radius of curvature is greater. Therefore, the lateral movement is greater. So it is less desirable placement method to put the thorax belt just below the armpit. And the correct placement should be at the level of rib number 5 and rib number 6. The abdominal effort belt should be placed above the umbilicus, and both the belts can record breathing depth, can help us to understand the phase relationship in order to assess the paradoxical breathing. Also, it can help us in the classification of apneas and hypopneas. In order to understand the principle of the RIP technology, you have to consider the following. An elastic belt into which a zigzagging coiled wire is sewn that is worn around the thorax and the abdomen, so it measures from the whole circumference of the chest wall. AC is passing through the belt, generating a magnetic field. Changes in electromagnetic properties of these coils during breathing are recorded as electrical signal, and the summation of the two signals when calibrated correlates with the tidal volume of the breath. This table summarizes the pros and cons for the RIP technology. As a pro, this technology can detect easily the patterns of abdominal breathing, like synchronization and asynchronization of breathing. The cons are that it semi-quantitatively measures the tidal volume during sleep, and when changing body position during sleep period, the relationship between tidal volume and RIP would change. And because of changing body position during the night, the belt may slip. That would result in inaccuracy in the measurement. The other recommended respiratory effort sensor is the esophageal manometry, where a catheter is to pass invasively through the nose to be positioned in the esophagus. The inflated balloon measures the pressure which is generated by the chest and esophagus during breathing, and it is directly proportional to the intrapleural pressure. When inspiration, the diaphragm contracts, the rib cage expands, which in turn will cause the pleural pressure to decrease. Fluctuations in pleural pressure is directly proportional to the fluctuations in the esophageal pressure. Esophageal pressure manometry can help us in distinguishing central hypopneas from obstructive hypopneas. The PVDF belts, which is an accepted method. The belt reacts to changes in pressure, strain, temperature, and impedance, making it a potentially useful substrate to sense respiratory efforts. The last technique, which is the piezoelectric sensors. This is also an accepted tool. Piezo means squeeze, a crystal that produces a voltage when stretched. This table summarizes the pros and cons for this technology. Piezoelectric sensors are inexpensive and simple. The cons are that if the belt is stretched beyond the limits, the polarity would be inverted, and this can lead to misinterpretation of paradoxical breathing. Also, calibration is not possible. In this drawing, the first two traces are for the flow, nasal pressure and thermistor. Second two traces are the RIP thorax and RIP abdomen. Last two traces are piezothorax and piezoabdomen. The breathing pattern is sinusoidal breathing, so there is no abnormality here. In this example, there is an evidence of a hypopnea with flattening, distortion in the inspiratory portions of the flow. And if we look at the thorax abdomen from RIP belt, we can obviously see that the effort is also affected. If you look at the piezothorax and piezoabdomen, we can see that the effort is less affected than when using the rib technology. In this example, there is an evidence of an apnea. If we look at the rib thorax and rib abdomen, we can see that the effort is still continued throughout the apnea period. So this apnea is classified as obstructive apnea. However, we can see that there is a degree of paradoxical breathing. There is a delay or there is asynchronization. If we look at the piezothorax and piezoabdomen, we can see that there is no evidence of paradoxical breathing here. That happened due to the fact that the belt was stretched, and this caused the polarity to be inverted. In this example, this is an apnea based on the flow, based on the rib thorax and rib abdomen. The effort is continued throughout the event, therefore, this event should be classified as obstructive apnea. However, if you look at the rib thorax and the rib abdomen, you can obviously visualize that the paradoxical breathing is severe, and at the same time, if you look at the recorded piezothorax and piezoabdomen, you would see minimal effort. That would mislead you to score central apneas. Oximetry measurement, that is expressed by the percentage of the saturated hemoglobin, which calculates the ratio between the absorbed oxydeoxyhemoglobin and the maximum averaging period of 3 seconds is recommended. Here are the different SpO2 sensors that can be used. To sum up, for airflow, we should use both of the nasal thermal sensor and nasal pressure transducer during diagnostic studies. So oronasal thermal airflow is to score apnea, nasal pressure transducer is to score hypopnea, PAP device flow signal is to score both of apneas and hypopneas if it is titration study. For the respiratory efforts, we should select one of the sensors. The dual thoracoabdominal rib belts, esophageal manometry, dual thoracoabdominal PVDF belts, that is acceptable. Oxygen saturation, the recommended sensor is the pulse oximetry. Snore sensors, there are two different types of snoring sensors. The microphone or the acoustic sensor, that can record all of the respiratory sounds, including snoring, groaning, stridor, and any other respiratory sounds that may happen. Piezo sensors, that is to be placed over the vocal cord, and it's based on the vibrations. In this slide, you can see the different available piezo snoring sensors and the microphone snoring sensors. Alternative sensors. When we are using the respiratory inductance plethysmography, we can get the following signals: the thorax and the abdominal movements and effort, the rib sum, which is a summation of the thorax and abdomen that is related to the tidal volume, and the rib flow, which is the time derived of the rib sum signal. When the rib sum is calibrated, this can give an estimation of the tidal volume. If not calibrated, it may allow detection of the relative change in tidal volume compared to the baseline breathing. If the signal is not available, a reduction in tidal volume can be inferred if there is a reduction in the excursions of the thorax and abdomen belts. Rib flow, is a semi-quantitative estimate of airflow in calibrated rep and relative airflow in uncalibrated rep. During apnea, it should show absent or minimal excursion. During hypopnea, it should show diminished excursions compared to the baseline. In flow limitation, it should show subtle qualitative changes in the inspiratory portions. This is an example where you can see cannula trace, exflow trace, exam trace, thorax and abdominal movement. And here you can see how reliable is the exflow to the nasal pressure cannula. So when supplementing a patient with oxygen or when monitoring end-tidal CO2, we will lose the chance to monitor nasal pressure cannula. In this case, exflow and exam can be used as alternative methods to score hypopneas and apneas. In titration studies, PAP device flow can be used as an alternative method for detecting apnea and hypopnea. And here you can see normal sinusoidal breathing pattern. And this is an example when the pressure is not sufficient. So for recording snoring, we have to select one of the following sensors: the acoustic, piezo, or nasal pressure transducer. For hyperventilation, arterial PCO2 if it's diagnostic or PAP, transcutaneous PCO2 if it's diagnostic or PAP, end-tidal PCO2 if it's diagnostic only. Pulse transient time. It refers to the time it takes a pulse wave to travel between two different arterial sites, and it provides an invasive measure of the inspiratory effort and arousals that can be used to document OSIS. This is the worksheet template in RimLogic. If we split the window horizontally, we can get two different views for two different worksheet templates on two different time bases. So here we have the neurology, and it's over 30 seconds. The other one is for the respiratory, and it's on 5 minutes. The black bar is called the indication bar, and the function of this bar is to synchronize the time. When we set two different worksheet templates on two different time bases, the first trace in the second worksheet template is the PTT signal, and then we have the flow, thermistor, thorax, abdomen, and desaturation. If we look at the EEG signals, here we can see that there is no evidence of EEG arousal. And if we look at the respiratory event that precedes the amplitude bar, we can obviously see that this event fulfills the criteria of hypopnea. If we look at the PTT signal, which is on the top, here we can see that there is no significant change in the amplitudes of the PTT throughout the event. Which means that when there is no EEG arousal, there will be no significant change in the PTT amplitudes. This is another example. If you look at the indication bar on the EEG channels, you can see that it is preceded by an evidence of arousal. Respiratory-wise, we can obviously see that the indication bar is preceded by a respiratory event. If you look at the PTT signal, you can see that there is a remarkable drop in the amplitude, where the amplitude increases until the event is terminated. If you have any concerns, questions, please contact me at my email or directly at my mobile number. This is the end of the presentation.